This is Carolyn Osuyos with Elderwerks. We are just getting ready to hear Katie Monahan talk about palliative care. It's not what you think it is. Katie Monahan is the Director of Community Relations for Transitions Hospice. She provides continuing healthcare education for both the professional and consumer, builds partner relationships, manages social media for the business, and guides prospective patients through the palliative care and hospice process. Katie earned her Bachelor of Music in Music Therapy from Alverno College in Milwaukee. She has 16 plus years in the healthcare industry. She began her career as a music therapist with the Wisconsin Conservatory of Music, working with the geriatric population, became a resident social service coordinator for dual diagnosis seniors, worked as a property manager in low-income senior housing, was the marketing director in skilled home health care, and assisted in opening an inpatient psychiatric hospital in Northern Illinois as the community liaison. A commitment to respect and servant leadership as organizational values brought her to her current role with Transitions Hospice in 2019. I'm pleased to introduce you here and now, Katie Monahan. Thank you very much. Take it away, Katie.
Thank you so much, Carolyn. Of course, you know, doing all of that in my past life, I obviously started working when I was 6. But thank you all for joining me today on a topic that is very near and dear to my heart. We're going to be discussing palliative care. Palliative care isn't what you think it is. Unfortunately, we have a lot of individuals who hear the term palliative care and they immediately think hospice. They immediately think end of life, and they immediately think that it's all about death. So today we are here to help make sure you understand that palliative care is about so much more and is a really valuable service that many, many individuals can benefit from of all ages. So what is palliative care? Palliative care truly is specialized care for individuals with a very serious illness. And we do focus primarily on providing relief from symptoms that can come along with serious illnesses, chronic conditions, and acute symptomology. Our goal is to make sure that we are improving the quality of life for both our patient and the family. You know, and as we say at Transitions, our motto is, it's about living. So what can we make sure that you have the best quality of life while you're going through any sort of treatment that you might need? We kind of think of palliative care as that perfect combination of expert care and truly loving consideration. There's a lot of different things that we have to look at with palliative care, with the idea that we are looking at what the patient wants and what the family wants. Obviously, patient-centered, based on the fact that the patient is always in the driver's seat. We are coming in and acting as the vehicle to make sure that the patient gets the best quality of care that they want. And we do that by anticipating, preventing, and treating suffering. So however you want to define suffering, can be pain, it can be discomfort, it can be agitation, it can be anxiety. Under palliative care, those are the symptoms that we work to manage. We also address the intellectual, emotional, social, and spiritual needs through palliative care, because our team allows us to go ahead and switch into different varieties as we need to while we're providing that care. Hang on, we have a chat running real quick, making sure I don't have any questions. All right, fantastic. Also, we really work to facilitate patient autonomy. Again, a patient needs to be able to make their own decisions. Or in the case of an individual who has an activated power of attorney, that power of attorney needs to be able to make the best decisions possible for their loved one. So we make sure to provide immediate access to information about the resources available, the type of treatments available, the type of care we can provide, as well as helping them understand the choices that they can make as they move forward. So palliative care is available for individuals at any age and any stage of any diagnosis. A lot of people have probably heard of palliative care being used during cancer treatment, and that's usually the one that people think of most often. So when an individual is receiving cancer treatment, it might be chemotherapy or radiation or immunotherapy, and sometimes even surgeries. But there are a lot of side effects to that treatment. Somebody might be experiencing nausea. Somebody might be experiencing insomnia. Maybe someone's experiencing anxiety or depression. So under palliative care, we come in to treat the side effects that someone is experiencing while the doctors and the oncologists are continuing to go ahead and treat their cancer. So we use palliative care alongside curative and life-prolonging treatments. And these can occur at the same time as these active and aggressive treatments. And we don't have any life expectancy limits under palliative care. Under hospice care, people often think, oh, well, we can only do it once we have 6 months or less to live, which is true. But under palliative care, we don't have any limitations. And the team is made up of a palliative care physician, a nurse practitioner, and a social worker. These individuals are able to work together in conjunction with a patient's primary care or specialty physician, as well as their team, to make sure that the whole person is treated rather than just the specific diagnosis that we're looking at. Our goal within palliative care is to really effectively manage a patient's plan of care and symptoms. So we're going to go ahead and work individually with each patient, because as we know, we can't use a one-size-fits-all approach, and make sure that we are effectively looking at what that individual wants to get out of their care. Again, if you're going through a treatment process that's causing a side effect like weight loss or weight gain, we can go ahead and work from a palliative standpoint to figure out how to go ahead and minimize that loss or that gain through other types of therapies and resources available. Additionally, we can often reduce unnecessary hospitalizations. So for individuals who are seeking palliative care, while we are not replacing their doctor, we do have the nurse practitioner who can come and visit a patient in their home, wherever they call home, to go ahead and make sure that there's a little bit more on-site medical management of their care. We also engage all of our patients and families in informed shared decision-making about healthcare and related goals, because we can only make decisions about what we know, not what we don't know. So we work very, very diligently to educate all of our patients and families about what their options of care are. If we're going to talk about a certain medication change, we're going to talk about the side effects of that medication, or why it might be beneficial for us to substitute that medication for something else. Oftentimes, when we start working with patients, we see patients who are on a number of different medications. And sometimes some of these medications are to treat side effects of other medications that they're already on. So we start every patient with a medication reconciliation and identify what is the best course of action so that we can make sure that we are minimizing risk and making sure to still meet their needs. We also make sure to go through repeated goal setting and advanced care planning discussions, because sometimes things change. And as goals are achieved, certainly at that point, we can look at discontinuing palliative care services. But in other situations, when we find that goals aren't able to be achieved, Sometimes we have to shift the direction and figure out what's the best plan of care and plan of action for our patients and families. Maybe the cancer treatment that was working in the last round isn't working in the current round. And so we have to start thinking about decisions of what we're going to do in case that this treatment isn't working, and we do have to look at end-of-life planning, because we certainly want to make sure that everyone makes the decisions that they want to make for the rest of their life while they're able to do so, and give the gift of advanced care planning to their families so that their families know what they would like to do. Some of the other goals that we try to achieve through palliative care is eliminating and reducing pain or discomfort. For any of us who have woken up in the morning with a stiff back or sore shoulders, sometimes that's just the minimal of what somebody is experiencing through some of the various treatments that we are working with in palliative care. So if we have the ability to reduce discomfort and reduce pain, we can automatically get to an improved quality of life. We also want to improve quality of life however we can for our patients. And that means we have to discuss with them what improved quality of life means. Remember how I said that it's not a one-size-fits-all approach? That's exactly what we're doing. We also try to decrease fatigue and improve mood. And sometimes that means that we're working with things to treat anxiety, things to treat depression, or trying to also figure out how we can help people sleep better. Our frequency of visits are really based on medical need. So not everyone is going to get a visit every single week, because not everybody needs a visit every single week. For some of our patients, we can see them once a month. For other patients, we might see them twice a month, or some even every single week. It really is just dependent upon what their needs are. As I mentioned before, the visits can occur wherever a patient lives. So that could be in a private home, in an apartment complex, in an assisted living or memory care, in a skilled nursing facility, even in a hospital. We work very diligently to make sure that we're also working with the entire care team at a facility, if somebody lives in a community, to make sure that that individual has a complete care plan among all individuals. We also work to assess and address family dynamic issues, because of course, not everybody has a perfect family, but we certainly want to make sure that everybody has access to important decision-making that needs to occur. Just yesterday, I met with a family who's very concerned about their 91-year-old mother, and she is able to make her own decisions at the moment, but we understand that she also has the beginning signs of dementia, and that she may not have the opportunity to be able to make those decisions as we progress through treatment. So we're going to be working very, very diligently with the family to make sure that advanced care planning occurs and that we have a power of attorney put in place when she's no longer to make those decisions for herself. Anytime we have the opportunity to, we want to make sure that we are enhancing communication between our physicians, our patients, our families, and of course, staff members in various communities, if that is applicable. We have a question that's popped up that I've heard families complain that their patients are over groggy. And of course, that is something that we can address. That sometimes can be based on certain medications, which is why we start every single palliative care assessment with a medication reconciliation. Sometimes we can see that side effect of medications as being that grogginess, that tiredness. Some people have even referred to it as snowing their family members. And our goal is to make sure that we can meet the needs of our families while also making sure that we're meeting their medical needs and we're managing their conditions. As I talked about before with an interdisciplinary team, it's a layer of support for everyone involved in the care. Our palliative care physician oversees every single one of our cases, but does not replace a patient's primary care physician. She's instead there to go ahead and oversee what's going on with our nurse practitioner and our social worker, as well as to be able to understand if we need to go ahead and move in different directions, because we want to be able to pivot as quickly as possible if there is a necessity to do so. Our nurse practitioners are the primary driver within our palliative care team, and they will actually physically go out and see patients in person, or we also have the option now to see patients virtually through telehealth with the necessity that has been provided by the current pandemic. Our nurse practitioners will be able to have that relationship with an individual and also be able to see them in their home environment, which can be really beneficial, as we know that the doctor only sees you in the doctor's office. But when we can bring that doctor to you in the form of a nurse practitioner, we can now see everything that's going on surrounding you. So we know if you need an extra grab bar in the bathroom, or if you would benefit from a raised toilet seat, or if you really have the ability to accommodate a hospital bed in the room to make sure that somebody has access for safety and the ability to be able to get in and out of bed. The last part of our interdisciplinary team is our social worker. Our social worker is there to not only support the patient, but also the family. And that can be in accessing community support and community resources like a private caregiver or an elder care attorney, or being able to process things like a provider order for life-sustaining treatment, commonly referred to as a DNR form, or being able to identify if maybe a home environment is no longer safe for someone and help them in connecting with companies like Elderwerks to be able to find an appropriate living situation, whether it's assisted living, memory care, or skilled nursing. I mentioned a little bit about the pulse, and that's one of the other things that we can help with from that social services aspect. That provider order for life-sustaining treatment is something that we really hope that everyone will go ahead and complete, regardless of their age. And it really helps you make the determination of what you want to look at your end of life, or should an emergency occur that you're in a situation that you can't make decisions for yourself. I myself was in a motorcycle accident a number of years ago. And obviously, as a younger individual, I want everything done in order to be able to preserve my life. And I had to make sure that my family knew my wishes, because if I'm in a situation where I can't make those decisions, I need them to be able to make those decisions for me. We also want to make sure, in that same vein, that a durable power of attorney for healthcare is identified. Anyone over the age of 18 should have a durable power of attorney for healthcare, because again, you don't know what can happen regardless of your age. You know, we certainly all want to live long, healthy lives, and make sure that we are, you know, getting as close to that 100-year mark or over if possible. But sometimes accidents happen. So we need to make sure that we have people who we trust and who know our wishes, who will go ahead and make sure that those take place for us. Additionally, we work to advocate for our patients. So if a patient is at a point where they are no longer really feeling the benefits of their treatment, or maybe at that time the benefit of the treatment is outweighed truly by the cost of the treatment, we can go ahead and make sure that we can take care of our patients as best as possible and give them the resources that they need. We also try to help our patients age in place as much as possible. So we will work to provide every resource that we can to make that happen. Maybe that is bringing in a private caregiver, or maybe it's identifying what resources through durable medical equipment we can provide in the house to go ahead and have for them. Sometimes it's also bringing in ancillary services like home health care. Sometimes individuals are finding that their mobility is limited, or they are not able to move around as much and transfer as easily as they have before. So we can bring in home health care to make sure that somebody has the ability to go ahead and receive that skilled nursing care, physical therapy, occupational therapy, and even speech therapy services available through home health. I mentioned already about the equipment, and certainly our goal at the end is to make sure that we have individuals spending less time in the hospital and in their providers' offices and more time living their life the way that they really want to. So who do we think can really benefit best from palliative care? Really, anybody who has a chronic or a terminal disease. This can be chronic pain, it could be breathing difficulties, it could be reduction in ability of where someone previously was. We've had a number of individuals with dementia and various types of Alzheimer's symptoms that have been on palliative care with us to go ahead and manage some of their disorientation, sometimes their agitation or restlessness. Anyone who's actually been frequently to the ER or has had multiple hospitalizations. We just recently started working with a woman who has been hospitalized 10 times in the past 6 months for a number of issues, but primarily because of her breathing. She has a diagnosis of COPD, and she is not able to manage her breathing on her oxygen at this time. So we're looking at what we can do to help her better manage that and figure out how we can help her best and keep her at home, because she certainly doesn't want to be in the hospital that much. As she says, the food isn't all that good. Also, for individuals who have a serious illness that also includes deteriorating wounds. We've had a patient in the past who was a paraplegic, meaning that they were paralyzed from the waist down, and was pretty much bedbound and chair-bound, and ended up with a number of sacral wounds, or rather wounds on their backside. And the wounds became very serious to the point that the patient could actually no longer be on their back and had to be on their side or on their stomach. So we worked very, very diligently with home health care to get to the point that we could get those wounds healed so that they could go ahead and be able to get back to their previous life, as well as then providing the appropriate equipment necessary for them to be able to be seated in their wheelchair so that they could go back to being out and about. Some of the common diagnoses that we see are listed on the screen right now. I certainly won't go through every single one of these, but I would say the most common diagnoses that we see right now really are congestive heart failure and COPD, along with cancer and dementia. So those top 4 that we have there. And I would say that the indicators that we are really seeing is that hospitalization frequency, as well as difficulty managing behaviors. That we see that specifically in our dementia patients. And it can be very, very disheartening for family and individuals caring for a loved one when they are agitated, when they do experience delirium, when they're not able to enjoy themselves and participate in their care. So we work very diligently to see how we can manage those through both pharmacological and non-pharmacological ideals. So whether we're using medications or not, sometimes we're able to meet their needs by adjusting our timeline of our day. So maybe we know that an individual experiences sundowning. So for those of you who haven't heard of sundowning before, it's when agitation starts to occur as the sun starts to set, can be anywhere between 3 o'clock and 7 o'clock in the evening. And individuals tend to become a little combative or resistant to care. So what we can do at that point is, from a non-pharmacological intervention, work with their care team to keep them active and make sure that maybe we're going on a walk or we're doing something a little bit more physical at that earlier end of that, so that we can keep people engaged rather than necessarily putting them on another type of medication to go ahead and help treat that. As we move forward here, the biggest question that I get from everyone is, okay, so we have this palliative care and we have all this wonderful stuff that we're going to do, but who pays for it? And how much is this going to cost me? Well, the reality is, While hospice is covered 100% by Medicare, palliative care is actually covered at 80% by Medicare, and the supplemental insurance picks up the other 20%. We are also starting to see Medicaid covering palliative care a lot more, as well as private insurance picking that up as well. So while I know this slide unfortunately is talking about hospice, under the palliative care side, 80% is picked up by Medicare Part B. Supplemental care picks up the other 20%. Medicaid does cover a lot of palliative services, and we are seeing more and more private insurances now that are picking up that service as well. So under the transitions tenets, we have to sort of follow these ideals every single day for our patients, and they are acceptance, empowerment, peace, and freedom. So we'll go into each one of those to help everyone understand a little bit more about how that works. So acceptance is the idea that we understand that some of these diagnoses can be overwhelming. I don't know anybody who has been excited about a cancer diagnosis, but we accept that we now have a new process to move forward. And it doesn't mean giving up. It means that we know we have to go through this process and that we are going to be there to help you as a team to help you through that situation and make sure that individuals have the support that they need to be able to get through that. Also, we look at empowerment because we know that knowledge is power. I know, I'm pretty sure everybody's seen that as some motivational poster on a wall somewhere. But the goal is for our interdisciplinary team to really empower our patient and families and create that individualized care of plan. I know I've said it before, but it's not a one-size-fits-all approach. So we have to make sure that we guide our patients and families through the decision-making process from start to finish, educating them about their options along the way so that they can be most comfortable in making the decision that they need to. Finally, we have peace. So we have this amazing comfort, support, and service available, and ours at Transitions is a little different than most other places in the fact that our nurse practitioners and social workers actually are available 24 hours a day. We have a nurse practitioner on call 24/7 to make sure that if there is a need in the middle of the night, you have access to that nurse practitioner who's able to go ahead and reach out to you. Oh, we do have a question from an attendee asking if palliative care covers medicine and supplies such as adult diapers. Unfortunately, palliative care does not. Palliative care does not cover medications or supplies like adult diapers. That's covered under the hospice benefit. However, we can work with your doctors as well as using our social worker to help find low-cost options or see if there are other services available to you that might be able to help defray the cost of some of those things. Finally, we have freedom. You know, we help our patients really live life on their own terms. Like I said, we make sure that it's about living, and we strive to guide our patients along that chosen path. You know, on our hospice side, our commitment is that no one dies alone. On our palliative side, our commitment is to make sure that you're never alone as you walk through that path. Our care locations can, again, pretty much be anywhere. And we're able to go ahead and work in private homes, which is actually where we see a number of our patients. The other place that we see a lot of patients right now is in assisted livings and in senior living communities. Because of COVID and some of the restrictions that were put in place, we are seeing a lot of those patients via telehealth. And for those of you who have not participated in a telehealth visit yet, it's actually very interesting. It's kind of like having a Zoom meeting with your healthcare provider. And it allows you to be face-to-face virtually and have conversations about what's going on with your care and what your symptoms are and what continues to need to be managed. This has been really great as a resource, as a lot of communities have sort of limited and restricted access into the buildings. But we are seeing a lot of communities that are more open now, and we have been able to come in and see face to face. But we even have some patients who really appreciated the virtual visit, and they've actually chosen to do that in lieu of a face-to-face visit. We are also seeing that specifically with our patients who are getting towards the end of their palliative care time with us, and their symptoms are well managed, and they really aren't in as much need of the palliative care services anymore. The other beauty about palliative care that I think people don't realize is that palliative care is something that can be used short-term or sort of longer term. So an individual that has an acute situation, like a cancer diagnosis, might only use palliative care for a short period of time while they're going through their treatment. And then once their treatment is effective and they are in remission, at that point, they may not need the palliative care anymore, so they can certainly discontinue it. In other cases, we have some patients who have elected to use palliative care as a longer term option, where our nurse practitioners are sort of functioning as their primary care physicians and able to come in and work with them on a monthly basis to check in and make sure that their symptoms are still managed. For one of our patients right now, we have a patient who needs a vitamin B12 shot. So we, under palliative care, have a nurse practitioner who's able to go in and provide that for that patient. You know, the beauty is that so many people don't seem to understand that they actually have a choice in this matter. You know, transitions is one option for palliative care, but there are a number of other palliative care companies out there, just like there are a number of other home care companies or assisted livings or senior living complexes. The best thing that you should do is making sure that you are interviewing the companies and make sure that you feel comfortable and that you are getting the best care that you feel you can get. For some people, that may be with transitions. For some people, that may be with another company. But the beauty is that you have the choice to be able to go ahead and manage that yourself and make those decisions, which I know is a little weird coming from an individual working for one company, but we certainly want to make sure that people are looking at all of their options and making the decisions that is truly the best option for them. I want to end quickly with sort of the functional difference. Oh, hang on, making sure I have one more. Nope, good. No more questions on that one. I want to make sure that people understand the functional differences between, oh, hang on. Looks like we got another question here. Oh, I'm so sorry about this for the situation in Michigan. That one's really difficult. But the beauty is that what you can do, Elderwerks has some really great resources. You can always reach out to Elderwerks. They have a very, very large network, and they might be able to provide you with some companies in Michigan that can go ahead and assist with that as well. But while I have you looking at the palliative and hospice care screen, the functional difference that I always remind everybody between palliative care and hospice care. Hospice care is when we're looking at end of life care, specifically when we have 6 months or less to look at. Now, I will also say that no one has a crystal ball, and I've never met anybody who had an expiration date imprinted on the bottom of their foot. So remember that it's just a life expectancy of 6 months or less without seeking curative treatment. So that could be for an individual who is perhaps maybe has that cancer diagnosis and has decided that they no longer want to pursue chemotherapy or radiation or any other curative treatments. But remember, under palliative care, those active and aggressive treatments can occur at the same time. We don't have any limit of life expectancy. But obviously, as you can see, it's a much smaller team. We still have that physician, we still have that nurse practitioner and that social worker, and they are available to you by phone 24 hours a day, 7 days a week. But we're not going to see that daily frequency that we might see under hospice care. Also, while the hospice benefit covers medications, equipment, and hospice services, the palliative care services really only cover the services provided by that physician and that nurse practitioner and social worker. But again, that nurse practitioner has the availability to order medication changes, to order any sort of mobile imaging if somebody might need an x-ray or lab work to be done to come into the home, as well as home health care like physical therapy or occupational therapy or skilled nursing services. Our social worker can assist in helping to provide lower cost options. So if someone qualifies through various types of services for low cost or no cost adult diapers or diabetes supplies or anything else that somebody might be needing, our team will work very diligently to make sure that we're providing holistic care. And that also includes financial care to make sure that individuals have access to all of the resources that they need. I wanted to go ahead and keep this a little bit shorter because I know we still have about 12 minutes left. So are there any questions that anyone has in regards to some of the stuff that we discussed today? What is the time frame of palliative and hospice coverage? That's a great question. So palliative care can occur anytime a patient needs it and for as long as a patient needs it. There's really not a time limit on it. Also, if an individual goes on to palliative care and then discontinues it because they've met their needs, they can actually go back on again should they have reason to go on to palliative care services. With hospice care, an individual can be on hospice as long as they continue to maintain that diagnosis of 6 months or less to live and are showing progressive decline. The other interesting thing about hospice care is that individuals might go ahead and improve on hospice, at which point when they are no longer declining, they then graduate, which means they go off of hospice services. If they should start to decline again in the future and re-qualify for hospice, they can go back onto hospice services. My own grandmother graduated and went back on hospice services 3 separate times in the 3 years that she was on hospice. So it's a really wonderful benefit when people can use it, and it's great when people go ahead and graduate from it. If you're younger and not on Medicare, sometimes you can go ahead and take a look at your insurance. Most insurances now do have a provision for palliative services. It might not be as long, and it might be a little bit more limited than Medicare, but we go ahead and we make sure to run insurance benefits of every single patient, as should all palliative care companies, to make sure that there's not going to be a financial burden on the patient or family if they're going to elect to receive palliative care. Another question that we have, we say it's too early to tell, but what's the likelihood that palliative care will be applicable for COVID survivors that have continued breathing problems? That's actually a very, very good likelihood that palliative care will be available to those individuals. We're already seeing that happen for individuals that have exacerbation of COPD or other pulmonary issues. And we're able to make sure that those individuals receive the same kind of palliative care that they would pre-COVID, because now we're managing a chronic symptom. And we have to look at what those chronic symptoms might be. As we know right now, it is far too early to tell as to whether or not somebody is going to have long-lasting sequelae from any sort of from COVID diagnosis, or if they have any sort of long-lasting, what's the word I'm looking for, diagnostic issue that would come up. We're seeing right now, I was actually just speaking with one of my nurse practitioners. She's worked with dozens of COVID positive patients since February. And she's actually noticed of all of her patients who have recovered from COVID-19, they're actually back to their baseline. She's not seen any increase in any of their pre-existing conditions, and that all of them who have recovered have been able to recover back to their baseline. So that's, again, only a couple months out. So we certainly need more time to see what's going on with these patients as time goes on. But we will continue to go ahead and manage their conditions and their symptoms as they arise and as is necessary for working forward with them. Are there any other questions that I might be able to answer? We still have quite a few more minutes. Otherwise, we do need to remind everybody to please go ahead and fill out your evaluation. I hope that this was good information for you and helped you better understand why palliative care is such an important tool and resource for individuals looking at managing chronic conditions.
I have a question, Katie. This is Jennifer.
Absolutely.
I've had families contact me because their loved one is dying and they have pain, and their hospice organization is supposed to be managing pain. Should there ever be pain on anyone's face who's not got full cognition or is not able to speak?
We absolutely need to manage pain. And we also need to understand what those pain symptoms might be. Obviously, for us, when we're in pain, we're going to wince. We also have to look at what that wincing might be for some of the patients that we're working with, because if we are managing their pain appropriately, and if they're still wincing, maybe there's something else going on. And we need to work very carefully to make sure that we're meeting that need. And that should be done from a clinical standpoint. So our nurses are going to be assessing the patient on every visit. And we also make sure as a company that we don't leave until the symptom is managed. And if that means that we need to be there for 2 hours or 4 hours or 8 hours or 24 hours, we're going to make sure to do that. But no, our goal under hospice care, actually our goal under palliative care as well, is to make sure that we're managing symptoms, whatever those symptoms are, including pain. I hope that answers the question.
It does. It makes me upset when I hear that anyone has pain when they're, passing. My mother-in-law did pass away. She did have hospice. I must say hospice and palliative care is the best invention since chopped liver.
I couldn't agree more.
Yeah, it's not just for the person who's dying, it's for the living. And it really, it greatly influenced my husband's family and helped them through the process. I don't think they would have made it without hospice and palliative support.
I think everybody focuses so much, especially when we're looking at palliative care and hospice care, on pain management, symptom management. But sometimes there's an emotional management that needs to occur as well. Dealing with chronic illness, dealing with a potentially life-limiting diagnosis is very, very stressful. And while we are certainly making sure to manage the clinical side of that, we also have to manage the emotional side, not only for our patients, but also for our family members. None of us live in a bubble. None of us are completely and entirely alone on this earth. And for the individuals who are, give me a call. You are not alone. And we have to make sure that we're managing those needs. We most recently worked with a woman. She was taking care of her aging mother, and she had a difficult relationship with her mother. And she was the only sibling who was willing to go ahead and take care of her mom, who was a rather difficult woman, by the way that she described. And there was a lot of history and a lot of water under that bridge. And it was great for our social worker to be able to work with that daughter to help her process some of her emotions and her feelings about taking care of her mother and providing care for her mother when she never really got that same level of care from her own mom. You know, sometimes we don't know the full story behind everything that's going on. So when we have the ability to manage not only the physical, but also the emotional needs of our patients and our families, we really are able to finally bring forth that holistic model of care and making sure that we're caring for the whole person, because that's really what we are. We are one entire person. And if that's the only thing that people walk away from today, with, of course, a better understanding of what palliative care is, but also understanding that it's our right to demand to be cared for as a whole person, not just a symptom, not just an arm, not just a heart, not just a brain, but the whole person, then we will all be much closer to understanding how we have quality of life, regardless of how long we have left on this earth. And thank you, Barbara, for that kind comment. Very happy to be able to be here. And thank you so much, Elderwerks, for sponsoring this wonderful event and allowing all of this education to be provided to those who are out there listening and interested and wanting to know more.
Thank you, Katie. We appreciate you. You are very eloquent and simplify hospice and palliative for everybody. And so we're glad to partner with you in transitions. So we're going to go ahead and take this off of live feed and stop recording. If there's any questions, please do put that in the chat box for Katie, and her email is also there so you can contact her directly. We do have about 20-ish minutes before the next speaker.